Okay, great. Hi everyone. Welcome back to the IR Playbook series. My name is Jason Kim, and I'm a rising M2 at Chicago Medical School. And today we're going to be talking about IVC filters. Um, to be honest, when I first looked at this topic, it seemed to be pretty simple. It's essentially just a small implantable medical device that goes into a vein, and the procedure itself is pretty quick. But the more that I read about it to prepare this talk, the more that I realized that the interesting part isn't the procedure or the device per se, it's actually figuring out which patients actually need an IVC filter and then remembering to take it back out later. And so that's what I kind of want to focus on this session today. I use the IR Playbook chapter as my main source. And per Nick's recommendation, I also listened to an episode from the back table on IVC filters with Dr. O'Neill at Ohio State. And I'll point out a few of his tips as we go because they kind of helped me to understand why things are done a certain way. Okay, so here's the plan for today's talk. We'll first cover the disease itself, which is venous thromboembolism, and then we'll see why anyone came up with the idea of a filter in the first place. Then we'll look at the devices and a little bit of their history. And after that, we'll spend some time looking at who actually qualifies for a filter because that turns out to be the part most people get wrong. And finally, we'll go through how the filter is placed, what can go wrong, and how you can remove it. Awesome. So let's start with the basic disease, and that's venous thromboembolism or VTE. And it's just just a spectrum of the same problem. On one end, you have DVTs or deep vein thrombosis, which is a clot in the deep vein, usually in the leg. And on the other end of the spectrum, you have pulmonary embolism, which is a piece of that clot that breaks off and travels to the lungs. And this is a fairly common and serious problem. If you take a look at the numbers here, VTE happens in roughly 1 to 2 people out of every 1,000 each year and it causes about 100,000 deaths a year in the United States. The costs are pretty enormous too, around $10 billion a year. These numbers were from 2016, so I'm not sure exactly how much it's changed since then, but I'd imagine that the costs have only really increased. And just a note, we're catching it more of it now, partly because there are more risk factors in the population, and partly because we just do more imaging. So the risk factors are the ones you would expect from your other classes, older age, obesity. We have cancer, recent trauma or surgery, being immobile for a while, smoking, having higher estrogen, inherited clotting disorders, and having a clot before. And one practical thing that I learned is that it helps to notice where these consults are coming from. If a hospital has a big cancer center, they tend to see a lot of these filter requests because cancer makes patients more likely to clot. Okay, so let's take a look at the two ends of the spectrum a little bit more closely. On the left side here, we have DVTs. Again, it usually happens in the legs, where the clot blocks blood from draining out of the limb, and the patient gets a swollen, red, painful leg. And then there's these other rare but dramatic versions worth knowing about. If a clot burden is really massive, the the blockage can get bad enough that it starts to choke off the arterial supply too. And so the limb turns pale at first, then turns swollen and bluish, and in worst case scenarios, it progresses to gangrene that can threaten the limb and the patient's life. And so these stages have Latin names. Phlegmasia alba and Phlegmasia cerulidolens. But the main thing to recognize is that these clots can get pretty bad. And even ordinary clots can leave patients with long-term leg pain, swelling, and skin changes, which is called post-thrombotic syndrome. On the right side here, we have PEs, and a leg clot is the most common cause. The symptoms are pretty vague for PE, like shortness of breath, low oxygen, and chest pain that gets worse with breathing. And a PE makes it hard for the lungs to do gas exchange, and it strains the right side of the heart. And in severe cases, it can be fatal. And so, an arrow between these two boxes is basically the whole reason why these filters exist. If a clot has to travel up from the legs up to the lungs, then in theory, you can put something in the middle to catch it. Okay, so here's how the clots get diagnosed and treated, and I'll keep this part fairly quick. For leg DVT, the first test is usually an ultrasound, where the vein won't compress the way a normal vein should. For APE, the main test is a CTPA, which is basically a CT scan of the lung arteries, which can show where the clot is and can even show strain on the right side of the heart. There is an older nuclear medicine scan called a VQ scan. You guys might have heard of it if you guys already took your respiratory block medical school, but it's mostly saved for patients whose kidneys can't handle the CT dye. And so that's that. And then lastly, a D-dimer test that's useful when you think that a clot is unlikely because a negative result basically rules it out. So the main treatment for VTEs is anticoagulation, blood thinners, and in hospitals that's usually heparin, and for long-term use it's mostly these newer pills called rivaroxaban or apixaban, just because they're easier to use and it has causes less bleeding. Importantly, though, these blood thinners don't actually dissolve the clot directly. It actually stops the clot from growing and it lets the body break it down on its own. And now this box on the bottom right corner is the important one for us because it's basically the doorway into this whole procedure and this device. There are situations where you can't give a patient a blood thinner. For example, if the patient has an active bleed in the gut, a recent bleed in the brain, certain brain tumors, or recent surgery or trauma to the nervous system. And so those patients are the reason why these IVC filters exist. For everyone else, the answer is just to use anticoagulants. Okay, so before we get into the IVC filters that we use today, what did doctors use for these patients before? So the problem was really twofold. Some patients can't get blood thinners because they're at a high risk of bleeding, and some patients take blood thinners and they still throw a clot to the lungs, and so people needed another option. And so before the 1960s, the option was surgery. Surgeons would actually tie off or narrow the interior vena cava, and the goal was the same as a filter, which is basically to keep these like clots from traveling up and reaching the lungs. But they were doing this with open surgery on patients who were already very sick. And so, as you can imagine, this approach really never caught on because it had high rates of complication and death. And so that's exactly the gap that a less invasive filter was designed to fill. Okay, so here's a really quick history on how the filter came to be, and I think it's actually kind of fun. So the first one was back in 1967. It was called the Mobin Udin umbrella. It was basically a little plastic cone held up by six metal ribs, and it did catch clots, which is great, but the problem was that it caused the vena cava itself to clot off too often, and so it kind of fell out of favor. And so this is a picture of that type of filter. A year later, in 1968, was the Greenfield filter, and this is the design almost everything today is based off of. And what I like is the origin story on how this kind of filter shape came to be. It was actually created by a vascular surgeon who was working with an engineer from the oil industry, and the engineer had designed baskets that filter debris out of pipes in oil fields, and they realized that they could do the same thing to catch blood clots. And so that's where they got this cone shape from. And so over the following decades, the delivery systems got smaller, so you no longer needed surgery to place one. But again, the basic cone shape stayed the same. And then in the 2000s, we got optional filters, the ones that can be removed. And this was also kind of Something interesting that I heard from the podcast is that for a long time, doctors placed these IVC filters in almost everyone. But we've since learned that that was kind of overused, and it actually led to a lot of lawsuits. And so part of the practice now is being more careful and being more selective in which patients to put it into because of that history. Okay, so I'm going to get into talking about the three classes of the filters now, and there's three broad categories, and the difference is really about whether they're meant to come out or not. And so the first one is permanent. These go in and stay in and aren't designed to be removed. And so some older, well-known filters fall into this group. There are still a few situations where a permanent filter is your only choice, and we'll talk about those later on. The second one is optional, and this is the type that gets most oftenly used today. An optional filter can stay in for a long time or permanently if it needs to, but it's designed so that it can be pulled back out once the patient no longer needs it. And this third one is is the newest group, and it's called convertible or bioconvertible. And these are really fascinating because instead of it being removed, they actually change shape while they're still in the body, from a clot catching form into an open tube-like form. And the bioconvertible ones do this on their own about 60 days later. So you don't even need a second procedure to go in and take it out. And so this is a picture of the convertible bioconvertible filters. As you can see in the axial view, you'll see how it's kind of more like there's more stuff in the middle for it to catch the clot. And then after a period of a certain amount of days, oh, sorry, you'll see how it kind of opens up, allowing kind of the blood to flow through the vena cava. Okay, so I'm not going to go through this whole entire table because the individual brand names aren't really that important. I just want you to notice two things. The first is that the delivery systems have gotten smaller over the years, and each filter is rated for a maximum vein size. And the size number becomes important because the moment you measure the patient's vena cava, if the vein is too big, the filter won't work properly. The second point that I want to make is that a lot of these filters are made from a metal or an alloy that is made from nickel. So one simple thing you want to remember to ask the patient is if they have a nickel allergy before you place it. And the honest, practical takeaway is that when you're actually in a hospital, you'll really just use whatever filters the hospital stocks. So it's more important to know the device in front of you than to memorize this whole entire list. Okay, so this is the slide I'd really want you to take away because it's the core of this entire talk. In 2020, SIR put out guidelines for filter placement that line up with the ones from ACCP or American College of Chest Physicians. And the clearest reason to place a filter is when a patient has an acute clot, but they can't be given blood thinners. That includes patients who were on blood thinners and got a clot anyway, or patients who were on them and had a bleeding complication, and so now they have to stop. There's also a select group where it can be considered, which is patients getting a procedure to remove or dissolve a clot, since that procedure itself can knock pieces of clot loose. And then there's a group where filters are specifically not recommended. If a patient keeps clotting even though their blood thinners are working, filter isn't the answer to that problem. And placing filters just in case in trauma or surgery, patients who don't actually have a clot, used to be common, like I said before, but it isn't recommended anymore. Um, right. Continue on. Okay. But of course, in real life, real patients don't always fit neatly into those three columns. And so there's a gray zone in between, and that's kind of where the actual discussion happens between like a healthcare team. There are situations where filters get requested, but the evidence behind them is weaker. For example, a severe trauma patient with several broken bones who will be immobile for a while, a patient with a head injury or brain bleed where you can't start blood thinners, a large clot already sitting in the vena cava and it looks like it might break loose, or a patient who simply couldn't survive another PE because their hearts and lungs are already weak or their current clot is that severe. So, depending on the doctor that you ask, they might place a filter in these patients or they might not. And that disagreement is exactly why these decisions usually involve a team rather than just one person. And here's a point that I found most useful from the back table. Dr. O'Neill, he called this the trap for new attendings. When you're a new trainee, this looks like a simple, quick procedure. So it's easy to stop thinking hard about whether the patient really needs an IVC filter or not. But if you train somewhere that carefully screened these requests, you might not even realize that the screening process was happening. So when you like move somewhere new where the screening isn't happening, this and suddenly this judgment is your job, it might be a little hard for you to make that decision. And so if you're not careful, you can end up placing filters in people who don't really need them, and that becomes a problem. And so the question is never simply, can I place a filter? The real question should be, should I? Okay, so we've talked about reasons to place a filter. Now let's flip it around and ask when you shouldn't or can't. And most of these are pretty practical. First, you want to check the same basic labs that you would for any procedure that involves veins. And if the patient's blood is already too thin or their platelets are too low, you'd want to fix that first. Second, you actually need somewhere to actually put the filter into. So if the vena cava is completely clotted off, there's no landing spot. If there's some clots, usually it's fine, but usually you just have to be more careful. Third is the size of the vein, since it can't be too big or too small for the filters you have. And fourth, is being able to reach the vein at all, because occasionally a patient might not have any usable veins left, access veins left. One thing is that is not a reason to hold off is infection. A patient with an infection in their blood can still get a filter if they really truly need one. And as for timing, this procedure isn't urgent, like not middle of the night type of emergencies, but most of these patients are already admitted, and the goal is to usually get it within the next day or two. That's because they're very unlikely to throw a clot in the next few hours, so you don't need to rush in overnight, but you also don't want it to drag on for like over a week. The one exception being is if it is an ICU patient with a large PE who's already unstable. In that case, you might want to come in for after hours to place a filter. Okay. Now let's take a look at the actual evidence because there is a nice set of studies called the pre-pick trials, and together they tell a pretty clear story. So the first one was in 1998, and they took 400 patients with DVTs and split them into two groups. One group got blood thinners plus a permanent filter, and the other group got blood thinners alone. The filter group had fewer PEs early on, which makes sense. But the interesting thing is that over time, they actually had more leg clots, roughly double. So the filter helped with one problem, but it caused another. And so the 8-year follow-up told the same story over a longer period. Again, fewer PEs, but more leg clots, and that trade-off stuck around. Then came pre-pick 2 in 2015, and this is the one that kind of changed how filters are used. This time they use the modern optional removable filter, and they compare that with blood thinners plus a filter against blood thinners alone, so two types of groups. But the result was no significant difference in PEs, no difference in DVTs, and no difference in survival. And so through this second run of trials, they learned that simply putting in filters didn't help. So again, if you put those two studies together, the message is pretty clear, and that's if a patient can take blood thinners, adding a filter doesn't necessarily help them. And in the older studies, it actually caused more leg clots. And this is important. That doesn't mean filters are useless. In patients who generally can't take thinners, a separate study found that filters actually did reduce deaths. So these filters work, but only for the right patients, which is the one that can't be on blood thinners. And so this set of pre-picked trials um, is worth kind of explaining to the patient or the team requesting the filter. Great. So let's move into the procedure itself, and starting with the planning. Note that you don't have to delay the case just to get a CT scan, but if the patient already has one, you should absolutely look at it because it's free information. And you're checking for a few things. And that's, does the patient have one vena cava or an unusual duplicated one? Are the veins draining the kidney in a normal spot? How much clot is there? And is any of it sitting in the vena cava itself? And so one nice tip to note is to note is which bone in the spine lines up with the renal veins. And you'll confirm that again with a dye during the case, but it's helpful to get a head start to already know roughly where to look. On the right side of the slide here are common anatomical variations and how often they show up. Individually, they might sound pretty rare, but if you add them all up, it's a pretty meaningful chunk of patients. And I've also added diagrams here just in case you weren't sure what it meant. And so you can kind of see that there are lots of unusual anatomies, IVC anatomies. But the key point at the bottom here is that placing these IVC filters has a 100% rate, a success rate. The hard part isn't getting it in, but it's really about, again, just making the right decision and having a good plan for the patient. Okay. This diagram was pretty fun to make, but this is the most important slide for the actual technique. So let me go slowly. So again, we aim to place these filters below the renal veins, and that's for two reasons. The obvious one is to catch the clot before it reaches the heart and lungs, but we also want to catch it before it reaches the renal veins here. So the target is to have the top of the filter sit right at or just above the point where the lowest renal vein joins the vena cava. And so here, the reason why this spot is helpful is that if a clot gets caught in the filter and stops there, it's actually sitting right in the path where all of the blood pouring in from the renal veins is, and that constant flow of blood actually washes over the clot and actually helps the body to break it down. And so if you've placed your trap in the exact spot with the most flow, so you've placed the trap in the spot where most of the blood flow is going through it. To be fair, the studies show that there isn't really a big difference between placing it right at the renal vein versus a little below. So you aim for the target, but you don't have to necessarily be there like by the millimeter. What you do want to avoid is this very bottom here, where the common iliac veins join together to form the vena cava. And there are two reasons to stay away from there. First, the outcomes are worse when the filters are that low. And second, they're just a lot harder to remove because they're just so far from where you started. So sometimes if a patient has an abnormal um, like vasculature and the left renal vein is a lot lower than expected, you might have to place the filter a lot lower, but you don't want to do it by accident. Okay, so to place the filter, you have to get into the vein somehow. And there are two main routes, and that's up from the groin or down from the neck. The honest answer is that you should be able to do both by the time that you're attending, but let me explain how they differ. Either way, you have to go in from the right side. The vena cava sits on the right side of the body, so coming up from the right groin is a straight shot up, whereas coming from the left means you have to curve across, which is a little harder. If you go from the groin, the tip of your sheath is where the top of the filter will end, so you position it a little higher and then pull back into its place. A nice advantage that Dr. O'Neill mentioned in the podcast is that where you can rest your hand on the patient's leg, which steadies your movement as you're placing the filter. The only downside to this axis approach is that if the filter comes out looking a little wrong or it gets tilted, you're not set up at the neck, where usually the hook is, for you to fix it easily. If you go from the neck, it's the opposite, again, top down. The tip of your sheath marks where the bottom of the filter will sit, so you go in low and you pull back up to your target. The big advantage for this approach is that if the filter looks wrong, if it's tilted, you're already up there to try to grab it without new access. But the downside is that you're holding the whole system out into the air. So people say it's a little less steady than going from by the femoral approach. The real takeaway here is that you should just be comfortable in both ways, because eventually you'll get a patient where one route isn't available, and you don't want that to be the day where you're kind of learning the other routes. Okay, so now let me walk through the actual steps of a straightforward placement. First is access. Usually, like other IR procedures, you use an ultrasound to guide the needle to get into the vein. That's again usually from the right common femoral vein or the right IJ. Second is taking a picture of the vein, which we call a cavogram, and you put a catheter down near the where the leg veins join, and you inject dye. And this shows the width of the vena cava, its anatomy, and also where the lowest renal vein sits. If the patient can't tolerate contrast, you can use carbon dioxide instead. Third is you mark where the renal veins are. That's either by drawing on the screen or noting the level of the spine. And then you lock the table and the camera in its place. And this part matters because if anything shifts after you've made your mark, that mark is no longer accurate, and you might have to do it again. Fourth is deployment. You swap in your catheter for the filter delivery system over a wire, position it again below the lowest renal vein, and then you release the filter, making sure that it opens fully against the wall of the vein. Fifth is you take one more picture to check the position and make sure that it isn't tilted. Again, a little tilt is fine, but if it's um, tilted, what becomes a problem is when this hook kind of like rubs against the side of the vein. That's when you might have to go in and remove it and try to place it again. I'll also mention that there's this ultrasound technique that can be done from inside the vein, and that's called IVIS, which lets you place a filter at the bedside. It also lowers the radiation dose, which is useful in patients who can't tolerate that much radiation, such as pregnant patients. Okay, so these are just some few small practical tips, mostly from the back table that helped kind of make these steps more sense to me. The first is about the dye injection settings for the picture of the vein. There is a standard starting point that you adjust based on the patient's size. The second is to double check that the patient has a single normal vena cava and not a duplicated one by looking for blood flowing in from both sides of both renal veins. The third is that idea of marking your target and locking in everything in place, which is worth repeating because it's a step that often people forget. The fourth is that a single view can be misleading because the vena cava is actually more oval than round, so its measurement kind of changes depending on the angle that you look at from, that you're looking at it from. The fifth point is to inspect the device before you insert it, because the versions made for the groin and the neck deploy in opposite directions. If you grab the wrong one, it can deploy upside down, and apparently that does happen. The sixth point is to commit to the release in one smooth motion. Dr. O'Neill's point was that when a filter ends up tilted or in the wrong place, it's usually because someone released it hesitantly or got nervous, and they had to keep adjusting it. So the hesitation itself causes the very problem that you were worried about. Okay, so let me just quickly go through some of these situations where the anatomy is a little unusual. If a patient has a duplicated IVC, meaning that there's two of them, the ideal approach is to place a filter in each one so you can catch clots on both sides. And if that's not possible, you can place a single filter higher up above the renal veins this time, but that's a little less ideal. If the renal vein is in an unusual low position, you simply have to place the filter lower to stay below it. If the vena cava is unusually large, we call that a mega cava. There might not be a single filter approved to fit it. So, in one option is to place the filter in each of the two leg veins instead. And those are usually the patients who end up with a permanent filter. As for the pregnant patient, you place the filter higher up above the renal veins, and that's because the growing uterus can actually press on the vena cava and could push the filter out of place. The reassuring thing is that most of these filters kind of go in the standard spot that we talked about, and these are just some of the exceptions. Okay, so now let's talk about what can go wrong because no procedure is free of risk. The common issues are things like a bruise at the access site, a clot forming, or a small abnormal connection between the artery and the vein from the filter's legs. Access site problems are they're pretty rare now, thanks to ultrasound guidance and smaller equipment. The delayed problems are more specific to the filter. It can kind of shift out of position. A component of it can actually fracture and travel and um, kind of go to the lungs. Its legs can kind of another thing is that its legs can poke through the wall of the vein into nearby organs, or the vena cava itself can clot or narrow around it. The good thing is that these numbers are actually pretty low, and even when they happen, the patient usually does pretty fine. As for these filter fracture, this percentage, we don't actually know the true fracture rate because a lot of what we know comes from individual case reports. That said, there are real reports of a filter or a broken piece traveling all the way up to the heart and lungs and causing serious problems, which is kind of ironic because the whole point was to protect the lungs. And the box at the bottom is pretty important. The FDA put out safety warnings in 2010 and 2014, and the main message was that these filters need to be removed once they're no longer needed. And it's the doctor who placed it who's usually responsible for following up for that removal. Okay, so let's talk about removing the filter now, which honestly might be the part that gets forgotten the most. The key point at the top here is that leaving a filter in, like we talked about with the pre-pick trials, actually raises the risk of DVTs. So it should come out when it's no longer needed. And so the next question you might ask is then when do you take it out? And the clearest reason is when a patient can safely take or tolerate blood thinners. Whatever the reason that they couldn't before, if that reason is gone, the filter can also come out. Another reason is that a risky period has simply passed, which is common for filters placed around a surgery or a trauma. And a third is if a problem shows up, like a fractured piece spotted on a chance or by chance or on a scan, which is a reason to remove it before it causes more trouble. The right side is building a system so patients don't fall in through the cracks. The doctor who placed the filter is responsible for following up, and a good habit is to write a note asking to be contacted when it's time for the filter to be removed. Some hospitals have filter clinics, which measurably improves how often these filters get removed. But there's also a team aspect because IR places a filter, but usually isn't managing the underlying condition. the underlying condition, and so the decision to remove it is shared. And one last nuance here. Removing a filter isn't always the right call. If a patient is very sick and another procedure doesn't kind of fit in with their overall goals of care, you don't have to force it. Again, it's about the whole patient and not just the filter. Okay. These are the standard steps for a routine removal, and it's kind of like um, the placement, but in reverse. The first step is actually before you get access at all. You'll take a magnified picture of the filter to check that it's still in one piece because you want to know if there's a fracture. You want to know that beforehand and not discover it mid-procedure. Then you can access, and here you usually prefer the right IJ, like from the neck. And that's because most removable filters have a little hook at the top that faces up towards the neck. Next, you take a picture of the vein to check two things, and that's is there a clot sitting in the vena cava or caught in the filter? And is there anything like tilting that would make the removal difficult? If there's a lot of caught in the filter, you don't have to force it. In that case, you would keep the patient on blood thinners and then come back and try again in a couple of months. Then comes the removal itself. You use usually an endovascular snare, which is basically like a little lasso to grab the hook at the top of the filter. And you just pull gently while sliding a tube over the filter, which helps it to collapse its legs. And so it comes through the tube. And then you have to make sure that you actually look at what you removed so that everything is there. And finally, you take one more picture to check that the vein isn't injured. For a well-positioned filter, this is usually a very quick procedure and most of them are pretty straightforward. Okay, before we finish it off, let me just tie this all in together with an example case that was from the chapter actually. So let's picture a 45-year-old man who was, let's say, a car accident and has bleeding in his brain from the injury. And so while he's in the hospital recovering, he develops a large clot in the leg. So let's think it through. He has a serious leg clots and he absolutely cannot be given blood thinners because he has that active bleed in the brain. And so if we kind of check that with our guidelines, this is the clearest possible reason for an IVC filter because this is an acute clot plus an inability for the patient to be on blood thinners. This isn't even a gray zone type of case. Again, for timing, it's not urgent, it's not a overnight type of emergency, so it can be done the next morning. As for the procedure, let's say we'll just go into the right groin, take a picture of the vena cava to find the renal veins, and then we'll place a removable filter in the standard spots in that landing zone below the renal veins. As for the part, as for the part that interventional radiologists tend to forget, and that's making sure that a note specifically asks the team to call for removal once the brain bleed heals and the patient can safely go on blood thinners. Because the only reason he really needs this IVC filters is for a temporary situation. And once that situation resolves, the filter should come out. Okay, so let me leave you with four simple takeaways to conclude this talk. First, anticoagulants are the main treatment of clots, and you only reach for an IVC filter when you can't use those blood thinners. Again, the pre-pick trials showed that adding a filter doesn't help patients who can take blood thinners. Second, the real question is always whether the patient should get a filter, not whether can you place one. I didn't mention this earlier, but a calf clot or a clot below the knee or placing a filter just in case doesn't necessarily qualify for a patient to get an IVC filter. Third, the filter goes in below the renal veins and you stay away from the confluence where the common iliac veins join. And fourth, you have to plan for removal right from the start because that's how filters avoid being forgotten, while still keeping the whole patient in mind. And that's everything I have on IVC filters. I just want to leave everyone with one thing that Dr. O'Neill from the back table said at the very end. He pointed out this IVC filter kind of seems like a back to basics topic, but it turns out it's not so basic after all. It's a simple procedure wrapped around a genuinely hard decision. Great, so I'm happy to take any questions if anyone has any.
Thank you, Jason, for that great talk. I'm curious about the pre-BIC trials. Do you remember what type of filter they were using? Do you know if it was the same filter? Um, was it like multi-center and they used different filters? And do you also know if they used permanent filters? Because I know that you mentioned that DVTs occur more frequently the longer the filter is placed in. So I'm wondering if that's the same case for permanent filters.
Yeah, thanks for that question. Let me go back to that slide. Yeah, so for the first set of pre-pick trials, they used permanent filters. And again, they figured out that having filters in for a long time actually increases the risk of DVTs. The reason for that is because if you learned about like the Virchow triad in medical school, you'll learn that the causes of clots are from like three things. It's stasis, hypercoagulability, and endothelial damage. And so if patients have a permanent IVC filter, it's essentially you're putting like a physical barrier in an area that has a lot of blood flow. And so that kind of increases the risk of stasis, which also kind of what they figured out increases the risk of DVTs. And also for the second trial, they did use optional filters. I'm not exactly sure what brand of filters that they used. I just know that the first series they use permanent, and the second one they use optional filters.
Awesome. Thank you.
Anyone else?
Hey, Jason, I had a quick question.
Yeah.
First of all, wonderful talk. My question was about when you mentioned the filters, when it's time to kind of remove them, and if there are clots that were still found there. It kind of made me think about over the course of having the filter there, if clots are caught within the filter, are they just naturally broken down by the body, or is there kind of another additional treatment that is undergone for the patient to get rid of those clots?
Yeah, that's a really good question. Um, yeah, again, these patients with these filters, um, they're for patients who can't be on blood thinners. But like I explained, they usually place it below the lowest renal veins. And the reason for that is because when the blood kind of flows in from the renal veins, that area is a place where there's lots of turbulent blood flow, which allows the body to break down the blood clots naturally. And so that's what I imagine the body just breaks it down naturally. And sorry, what was your second question again, Yahia?
I think that was it for the most part. Um, yeah, I guess it makes sense that um, being in a place where they can get broken down by the body's natural um, anticoagulation factors versus if it's stuck somewhere in the smaller vasculature.
Yeah, yeah,
If I
yeah.
followed correctly, yeah.
hmm Yeah, I'm not too sure about how what they would do to say that the clot burden becomes really massive. I'm not sure if that has any type of like contradictions or risks for the patients. I'm not too sure about that. But I think they usually, if they see a blood clot in the IVC filter, they wait for the body to break it down before taking it out.